Bom, nós vamos dar início à mesa de aneurisma de aorta. Naturalmente, o sucesso da mesa já está garantido pelos participantes. Eu queria agradecer muito o convite que foi feito a mim. É uma honra ser presidente de uma mesa com esses componentes. Eu estou que nem eu, como octogenário, eu vou dizer a mesma coisa que o Papa eleito disse, né? Acho que foram me pegar lá no fim do mundo, né? Foram se lembrar de mim. E eu, para poupar um pouquinho os moderadores, eu vou, então, chamar as pessoas que vão falar. Não sei se vocês ficam poupados, depois eu passo a moderação para vocês. Então, o primeiro apresentador aqui é o Dr. Chuter, dos Estados Unidos, que vai nos falar sobre quais os pacientes que não têm o substrato anatômico para o reparo vascular multiramificado, aneurisma de aorta tórica abdominal.
Which patients simply lack the anatomic substrate. These are my disclosures. As you can see, all the technology I use is either made by Cook or licensed to Cook. And this is the essential component that I'm going to be talking about. It's a stent graft that connects to a series of branches, not through fenestrations, but through these cuffs. And the cuffs are oriented in such a way as they fall on the inside from above and then deliver branches, catheters, whatever, below. So here you can see we're coming in through a brachial approach, coming out through a cuff, coming into a target artery, and then replacing the catheter with a covered stent that ultimately forms the branch of the device. And the most important feature of this approach is that you can be a little high, you can be a little low, a little to the right, a little to the left. It's a very forgiving system, as illustrated by this rather difficult case where we ended up with the right renal branch going to the left kidney and the left renal branch going to the right kidney. This patient's 3 years out now, doing just fine, and illustrates the potential forgiveness of the stent graft. Another consequence of that is that variable branch morphology can accommodate variable distribution of the arterial targets to the point where you can almost use one device in all the different cases. Of course, that doesn't account for the extent of the aneurysm, but if you add an extension proximally and distally, you can treat a more extensive aneurysm, type 2 aneurysm. So for those of you with a short attention span, here are the conclusions. These are what I would regard as the absolute exclusion criteria for endovascular repair of a thoracoabdominal aortic aneurysm. If you don't have anywhere proximally that you can put the device, that is, the arch has an aneurysm in it. If you don't have anywhere distally where you can put the device, usually that means that there's a dissection. The branches are dissected, the iliacs are dissected, and you have nowhere to implant that will not leave you with an endoleak. If you have small renal arteries, which usually means multiple renal arteries, they can be too small for the branches that we have available. If you have no endovascular route of access, that is iliac disease, you can't put the device in. And I've added this one on the bottom here. I consider rupture to be an exclusion criterion, since it's quite hard to completely exclude type 2 endoleak in such cases. We've done 115 cases, over 400 branches, and of all of those, only one branch were we not able to place in the intended location, basically because the aorta was folded between the SMA and the right renal artery. All of the others were completed in the intended manner. So let's take a look at some potential exclusion criteria. Narrow aortic lumen, here's the cuff, here's the target artery. There is no route to get from one to another between the artery and the stent graft. But actually, there is. You can always squeeze something through. Despite the compression and angulation of the pathway, you can get in there. And then once you're in, a series of balloon expansions and stent implantations, and you establish a pathway. As you can see, this is a rather small renal artery and a rather curved renal artery, but it did just fine. Also, in cases of dissection, the lumen can be even more compromised because the false lumen compresses the true lumen from which most of the branches will arise. But here you can see this is the kind of thing that you can do and end up with multiple target artery catheterizations. Well, what about if the branch is going up, cranially oriented, and not, as we often see it, going backwards or downwards? Well, in those circumstances, you can put cranially oriented branches on cranially oriented cuffs. What about if the target artery is small, as you see here with this celiac, that is basically being occluded in its area of stenosis by the catheter? Well, that's not really a problem. You just have to balloon dilate it, put a stent, and that becomes your target. If the artery itself is small, and as I said, the renal arteries is usually the problem, then that can be a little more limiting. A high aortic bifurcation usually signifies that the patient has previously undergone an open repair with a bifurcated graft with the usual short trunk. So you can see here's the bifurcation of the graft, here are the renal arteries. The standard device has too long a segment below the renal arteries to fit into this space. So what we do is we use a device with a shorter segment, and then we complete that with a shorter bifurcated component. Narrow iliac arteries usually means narrow external iliac arteries, and of course that's a problem if the device is very big, as some of the thoracoabdominal systems are. Our standard system is a 22 French, but we've now transitioned to a smaller 18 French, which is this. This is the tapered component, this is the bifurcated component, and this is a low-profile TX2 proximal extension. All of these are 18 French delivery systems. Of course, if you really can't get through the external iliac arteries, you can put a bypass. From this is going from the stump of the common in an end-to-side fashion here, retrogrades up, fills the internal. The real problem comes when the proximal common iliac is too diseased for such an approach. Well, what about if you don't have a common lumen? If you've got a false lumen feeding the left renal and a true lumen feeding the SMA celiac and right renal, well, then you've got a problem. You can see it a little bit more detail here. One of the things we've developed is a special endovascular jiggly saw by which we can connect the two lumens, essentially sever the septum in between them, and end up with this kind of a repair. But there are circumstances where you absolutely have no route from one lumen to the other. Here's a patient where the false lumen is feeding the renal artery and is receiving its blood through a fenestration in the SMA. So there really is no place to implant here, and there is no way to get to this target artery. What about patients who are at high risk of paraplegia, like this patient who's had an arch repair and has a thoracoabdominal repair as well? Well, you might consider that to be a very high-risk circumstance, but actually the high-risk circumstance is a patient who is at risk for embolism. All of the patients who've developed paraplegia, as I'll tell you later on in our series, have done so because they've had embolism, not because they've had an extensive aortic repair. That's not really as important a factor. We went back and had a look at 203 patients that we had looked at over the past few years. Of these, 68% were anatomically suitable, but another 21% could be made anatomically suitable by balloon angioplasty, an access operation, some other minor procedure at a separate stage, leaving just 11% of the patients who truly lacked the anatomic substrate. So I'm going to go back to this slide that you've seen already. The ones we cannot treat, there's no proximal implantation site, there's no distal implantation site, usually means dissection, multiple small renal arteries, especially in the presence of renal disease, and patients who have no route of access, and then probably add on at the end there, ruptured aneurysm as an exclusion criterion. Thank you very much.